remission. I'm going to talk a little bit about what to do in second treatment or greater, or how we approach this problem, and then a little bit at the end about some novel therapies or some new drugs available in CML. And then I have some time for your questions. Hopefully the talk, I think, is going to be about 45 minutes, and I'll try through it in that time so we have some time for questions as well. So about the epidemiology of CML. So it's still a relatively rare disease, and the incidence is estimated around 1.6 per 1,000 patients per year. And so in a country the size of Canada, where we have about 1 million patients, there's probably on average around 576 as a estimate patients diagnosed each year with CML. Many of these patients are diagnosed with CML or living longer or close to normal life expectancies. The actual number of patients in Canada with CML will be significantly larger than this. Studies report that there's a slight male predominance, although not all. And in general, it's still the disease of relatively older patients. Some younger patients for sure definitely do get CML, but the median age is still around age 66. For most patients with CML, we often can't pinpoint exactly what was the cause of their CML, although we do know that there's, based on studying incidents of nuclear disasters or nuclear radiation, that there does to be a relationship between radiation exposure and the development of CML, and in some cases this may also be related to prior chemotherapy. Typically present when they're diagnosed with CML. So it varies between patients, and there is a subset of patients that seem to present without any symptoms, where they just have an abnormal blood count or a CC that's done. But common types of symptoms that patients may report when they're first diagnosed are symptoms like fatigue or just feeling tired, symptoms of what we call B symptoms, or fevers, sweat, or night loss, or weight loss, and just general feelings of malaise or feeling generally unwell. It's really common for patients to have an enlarged spleen when they present with CML, and so the spleen is an organ that sits up under your left abdomen, and it's like a big lymph node. And as it enlarges in CML, it can potentially prey on other organs. Often the stomach is one that's affected, and so some patients can with symptoms that we call early satiety, or feel full early, sometimes having issues with nausea or vomiting, and some patients present with pain in the left quadrant or in the shoulder. Uncommon sort of presenting symptoms, but still possible, would be presenting with priapism or painful or erection, visual loss related to retinal hemorrhages. Occasionally, patients can present with symptoms of blood clots or bleeding, bony pain, large liver or hepatomegaly. Occasionally, patients might present with enlarged lymph node, although this is more common in other types of leukemias or lymphoma. And rarely patients can present with skin infiltration or actually a solid tumor, which we often call like a choroma. When we're looking at diagnosis of CML, there's sort of 4 kind of key at one is what we call a CBC, or a complete blood count, a blood film. And so on the CBC, we're often seeing an elevated white blood cell count. And when the cells underneath a slide, we often see what we call a left shift. And so that's what this picture up on the left is showing here. And you can see, and then you see all the pretty looking purple cells are all white blood cells. And what you're seeing there is you're seeing a number of abnormal, immature white blood cells that we usually just find in the bone marrow starting to spill out into the purple blood, which is abnormal. And then we see here, we see this picture of what we call basophils, and these are kind of purplish cells, soccer ball-looking cells. And these are often a clue that you could be dealing with a diagnosis of CML. We can't diagnose this on a blood film, and so we always usually get a bone marrow examination when a patient is initially diagnosed with CML. And this helps us confirm that the patient does in fact have CML, and also helps us assess what phase of the disease the patient is in. The other tests are cytogenetics tests and the PCR test. And for these tests, we're really looking for the presence of the Philadelphia chromosome or the BCR-ABL abnormality. And I'll go into this in a little bit more detail, but here's showing a picture of a chromosome where you can see that there's been a piece of chromosome 9 that's broken off and stuck onto chromosome 22. So the Philadelphia chromosome is chromosomes are kind of like the way that cells package up DNA and genes. And so in a human cell, we have 23 chromosomes. So, and they're labeled 1 to 22, and there's an X and Y chromosome. So women have XX and men have XY. And copies of each chromosome. So there's actually, I say 23, but there's actually 46 chromosomes because you have two copies. And what happens in the Philadelphia chromosome is that you get a chunk of the chromosome 9, and this breaks off, actually switches places with a piece of chromosome 22, and stick together. And what happens with this is that you get the gene called ABL1 on chromosome 9 and a gene called BCR on chromosome 22. And these genes actually become stuck together. And they actually form an abnormal new gene that we call BCR-ABL that doesn't normally exist in normal cells. And this is what we call an oncogene, where we think it's driving cancer or major, maybe not the only contributing factor to CML, but a major important genetic change in the development of a patient developing CML. And that gene was initially described first in Philadelphia in the 1960s, and so at that time it's kind of being dubbed the Philadelphia chromosome, and it's kind of stuck. And so gene, or this DNA change, what happens is that with this oncogene, you actually have it's getting traded into intermediate step that's called an RNA or mRNA. And this RNA is ultimately translated into a protein or a molecule that functions within the cell. And this BCR-ABL gene produces a BCR-ABL protein that has several downstream effects within the cell that ultimately leads to increased growth or proliferation of the cell, abnormal cell death. So the white blood cells don't die like they normally would, or through a normal life cycle of a normal white blood cell. And so, like, important reasons why we do a bone marrow examination when we see a patient with CML, because we could technically just do some of these FISH or PCR tests on peripheral blood, is to partly determine what is the phase of the CML. And here I'm showing a diagram on the left of the three different phases, so-called chronic phase, accelerated phase, and blast phase. Not all patients, but the majority of patients with CML, when they're first diagnosed, are diagnosed in chronic phase. And development of this pattern was that the average time that patients would spend this chronic phase was about 5 or 6 years. And this chronic phase was associated with patients sometimes being asymptomatic or having relatively manageable symptoms or more mild symptoms related to the disease. And this phase is also associated with a lower number of very immature cells, or what we call blast cells. And these blast cells are sometimes what we associate with patients who develop leukemia. And don't undergo treatment, almost all patients progress to what we call an accelerated phase. And this is associated with increased symptoms, so patients often become more symptomatic, as well as increased number of these immature blast cells, and sometimes can be associated with the acquisition of new cytogenetic changes other than the BCR-ABL or Philadelphia chromosome. And this accelerated phase, it usually isn't, it's a period of time shorter than patients spend in chronic phase, and it tends to invariably lead to what we call a blast crisis, where we get a high number of immature blast cells in the blood and the bone marrow. Patients become very symptomatic related to the disease. It's invariably, unfortunately, fatal when patients get to this point unless they're able to receive treatment or cell transplant. This is very important to determine this the disease because it's important in terms of impacting treatment up front and also how we manage patients on. And so the one important kind of thing to note is that there's a bunch of criteria that are by different groups and some of the criteria for accelerated blast phase, although they're similar, are not entirely the same. You can imagine that as we're defining these different stages of disease, there's some overlap in the different as patients transition between one phase to another. So here I'm showing the WHO or the WHO criteria as well as the European or ELN criteria. Most centers use the ELN criteria. We can see that the ELN criteria, there's a slightly higher number of blasts in peripheral blood or the bone marrow that define accelerated phase. We will see an increased number of basophils, nature of blast phase in the peripheral blood, and to develop counts that aren't attributable to treatment. Can also be a sign of accelerated phase. The action of certain new chromosome changes within the cell or progression of the disease. And then in last phase, in the ELN criteria, it's typically defined as more than 30% blast in the peripheral blood or bone marrow. And so, CML, the actual oldest types of leukemia that was originally described, and I think the original description goes back into the 1960s. At the time, there weren't a lot of effective treatments for the disease. One of the earliest drugs that was used in leukemia was a drug called arsenic, and that was used in the 1800s in patients with CML to reduce the white blood cell count and hopefully help with symptoms. And that drug is no longer used, but interestingly, it's actually used for a separate kind of leukemia now, acute promyelocytic or APL. In the 1900s, there was the development of radiation therapy, and it was used in some patients with CML to reduce the size of the spleen and help with symptoms. In the early 1940s and 1950s was when some of the first chemotherapy agents were developed, and the drugs, busulfan and hydroxyurea, were known to reduce the white blood cell count and help with symptoms related to CML, but they really didn't cause deep responses or really affect the natural history of the disease. One major breakthroughs in the treatment of CML was the development of stem cell transplant. And really the first kind of treatment that was available that was shown to be a cure for CML, and we still use it today in selected cases of CML that aren't responding well to other treatments. And the downside of stem cell transplant, even though it is a potential cure, is that it can be associated with a significant amount of toxicity and side effects to the patient. Following there was the development of combination chemotherapy, particularly for patients who presented in a more advanced phase, accelerated or blast phase. And interferon alpha. This is interferon is a what we call a cytokine or a chemical that's produced by the immune system, and it's important in our immune response against viruses, and probably also important in sort of immune surveillance against preventing certain cancers. And so this is studied in a lot of cancers, including CML, and it was actually one of the first drugs to show that patients could get deep responses and go into kind of remissions or cytogenetic remissions in the treatment of AML. It's not commonly used today outside of clinical trials. And really kind of modern era of CML treatment was hailed in by Imatinib, and then later on second generation tyrosine kinase inhibitors like Nilotinib and Dasatinib. And so Imatinib is a cell drug that inhibits the BCR-ABL protein, and I'm sure many people are familiar with the drug. And this is really shown to be sort of a standard of care or best care for the treatment of CML in a phase 3 randomized control trial, a large trial that was done at many different centers, including here in Vancouver in the 1990s and early 2000s. At the time, Imatinib was sort of one of the first medications that was actually sort of developed to inhibit a specific molecule within a cancer cell, and so-called sort of the first kind of targeted therapy. And this initial trial compared Imatinib to interferon and low-cytarabine, which was sort of like a standard of care treatment at the time. What this trial showed was that patients received Imatinib had lower rates of progression to accelerated or blast phase interferon, and the drug also resulted in significantly deeper responses. So patients had, what I'm showing there in that third point is that CCYR, complete cytogenetic response. That means that when you go to do a bone marrow on patients and you try to look for the presence of Philadelphia chromosome, it's really not there anymore. So that's what we call a complete cytogenetic response. Compared to the standard of line treatment, and that complete cytogenetic response was about 75% versus 14% in the interferon arm. And so that allowed for crossover. About 60 or 65% of the patients ended up crossing over from the interferon arm to the Imatinib arm because it was such an effective treatment. At the time, the drug was nicknamed STI-571, and at the time in the 1990s, really the first period of care for younger patients with CML who were eligible for a stem cell transplant was to go undergo a stem cell transplant when they were in chronic phase. And at the time, the investigators that were conducting the trial nicknamed the drug transplant immediately based on the name. And this is just showing a Time magazine cover, I think from 2001, kind of indicating that this actually had a huge impact on how we kind of view cancer treatment and targeted therapy. And so it really has made a big difference, Imatinib and then other tyrosine kinase inhibitors in terms of the outcomes for patients with CML. What I'm here is a registry study or graphs from a registry study or a population-based study that was done in Sweden. Sweden has very good population-based data where they're able to kind of follow the life expectancy for their general population and outcomes for patients with specific diseases. And what's showing here in these different graphs, say for this top graph on the left-hand corner, this is a graph of life expectancy over time from 1970 up to sort of a modern era in 2010. The x-axis here, and on the y-axis it's showing life expectancy. And this top blue graph, this dotted blue line is showing life expectancy for the general population in these different eras. And the yellow graph is showing life expectancy for patients with chronic myeloid leukemia. And you see that in 1970, there was a large difference between the life expectancy that had CML and the general population. And this was kind of in a time before there were lots of effective treatments for CML. Whereas the more modern era, the difference is very small. And actually, in all age groups, independent of gender or age, the difference on average less than 3 years. So we think that now most patients who are diagnosed with CML can probably expect to have a relatively normal life expectancy or an equivalent life expectancy to matched cohort. The thing I want to talk about in my introduction is how do we kind of measure the response to these drugs, because I think it's an important part in understanding some of the subsequent part of the presentation. So is that we monitor cytogenetics, and this is usually done in a bone marrow test. So we usually do a bone marrow at diagnosis. And probably before the development of PCR tests, we would often do bone marrows every 3 months to evaluate the response. But usually we only do a bone marrow again at 12 months if we're going to do it, or a year. The other we monitor test is off the peripheral blood. This is where we measure the BCR-ABL transcript. And this is what we call a PCR test. And usually we do this prognosis, and then patients are usually monitored every 3 months for the first couple of years, and if patients have a good response, and sometimes this is done less frequently after that. And then kind of special tests we can do in terms of monitoring response is we can screen for mutation in the BCR-ABL protein. Sometimes mutations can be acquired during treatment, and they can indicate that a patient is progressing or resistant to the specific treatment that they're getting. And with these different kind of measurements of response, there are certain targets that we're looking for when we're monitoring a patient when we start them on a new treatment or a new TKI. And one of the kind of basic or early responses that we're usually looking to occur within the first few months is a complete hematologic response or a CHR. And this really just refers to that when you have a patient that comes in with a high white blood cell count and a large spleen, that after starting treatment, that white blood cell count, platelets should go down to normal, and the size of the spleen should go back to normal. The other type responses that we're looking at are what we call cytogenetic responses, and this is done from these bone marrow exams that I mentioned. And kind of the major response that we're looking at is a complete genetic response, where when we do a bone marrow, we don't see that there's any evidence of this Philadelphia chromosome. Other types of responses are what we call molecular response, and kind of a major or standard type of response is what we call a major molecular response. And then we have this BCR-ABL transcript. When we measure it in the peripheral blood, it's at a level of less than 0.1%, which is a reference to a standard measure that I've kind of standardized the test again. We can actually, especially nowadays, as we have more and more sensitive PCR tests, we're able to measure this BCR-ABL transcript at lower and lower levels. And so other relatively newer kind of response categories would be called an MR 4.0 and an MR 4.5, where this BCR-ABL transcript is less than 0.0% and 0.03% respectively. And then a complete molecular response is where you don't have a detectable BCR-ABL test when you have a test that's at least as good as measuring MR 4.5. One thing to note is that although these responses are certainly not a bad thing, the main kind of responses that have been shown to predict survival in patients with CML have been this cytogenetic response and MMR, and it's not really clear that patients who have these deep responses actually have any better outcome in terms of the treatment of the disease. And so this is showing how we approach a new patient with CML and what we would consider sort of a failure of treatment in a patient that had newly started on a TKI like Imatinib or one of the second-generation TKIs. So if a patient hadn't had a complete hematologic response at 3 months, that's usually a sign that their treatment is not working well. A new kind of response target is this so-called transcript level of less than 10%, and this is described over the last 5 or so years, where it seems like patients who at 3 to 6 months who don't have this BCR-ABL transcript go down below a level of 10%, there does seem to be a higher risk of having to switch TKIs and progression of the disease. And then 12 months, we're really looking for this BCR-ABL transcript to be less than 1% to say that the treatment is a success. And this BCR-ABL transcript level 1% or less than 1% correlates to a complete cytogenetic response. And the patient's response time, then we often think of that as a failure of treatment as well. And so now sort of the new areas or kind of the new areas around treatment in CML. And the first thing I'm going to talk about is just frontline treatment goals for CML. So I think then before we kind of launch into some of the different treatment options is to think about, well, what are some goals that we have when we have a new patient that's diagnosed with CML? One of the obvious goals would be if that patient has symptoms related to the disease, is to reduce the symptoms associated with the disease, like it could be associated with splenomegaly or the so-called B symptoms that I mentioned. We all want to prevent progression in patients that are presenting in chronic phase to accelerated or blast phase. We want to extend the patient's life, hopefully to a relatively normal lifespan, and also at the same time kind of improve or at least maintain the current quality of life. And part of it ties into trying to minimizing the side effects related to the treatment of the disease. I would say that maybe there's going to be new goals, but I don't think these are establish goals at this time point. Perhaps in the future, there may be goals to kind of stop treatment, or what we call a treatment-free remission. And potentially, in the long term, maybe people will be talking more about the goal of a cure of CML. In Canada, there's really three line TKI or tyrosine kinase inhibitor options. Imatinib, which we call sort of the first generation TKI, or Gleevec is the other name, and then dasatinib and nilotinib. In the U.S., there's 4 treatments, so bosutinib is the new kid on the block, but that's not yet approved in Canada. And really no definite choice treatment for TKI, and there's other kind of considerations that go into a physician or potentially a health authority choosing a TKI as a frontline. Probably the main considerations are the first two, the toxicity profile of the different TKI, and this may impact selection for a specific patient, and then also, unfortunately, the cost of the medication also plays a part of the selection as well. And I say that perhaps in some centers, they may be starting to consider what's going to be the depth of the response, the medication. But I would say this is always a first-line consideration. And so this graph is kind of a busy graph, but what I'm showing here, I'm showing the kind of major outcomes for 5 different trials that led to the approval of the different front treatments for CML. So the first one here is the IRIS study, which I already mentioned, imatinib versus interferon and cytarabine. The second one is the so-called DECISION study, and that's imatinib versus dasatinib. The one here is the NSMD study, imatinib versus nilotinib. Here, and the 4th and 5th are 2 frontline studies comparing imatinib to bosutinib. And so in this first column is what's the rate of this important endpoint, what we call a complete cytogenetic response. And you see that across the trial, actually, the rates of cytogenetic response are pretty high no matter what drug you choose, usually around 80% or better in most studies. Look at major molecular response, which is a deeper response than this complete cytogenetic response. We see does seem to be a slight increase in the rates of major molecular response in people that are treated with, say, the dasatinib or nilotinib, bosutinib, the second generation TKIs compared to imatinib. It is relatively modest, but it tends to be in the range of around 10 or 15% between trials. Something important to look at in the trials is also what's the rate of discontinuation, or how many patients actually end up stopping the medication, and this can give us an idea about as well as also the side effects of the drug. So, say if a drug has high levels of responses, but if a lot of patients are stopping that medication for the toxicity, that's not a good thing. You can see that there was continuation of pretty equal across these different across the different trials between the comparator, the 2 different treatment groups, suggesting that the drugs are relatively equally well tolerated. And sort of the last column here is showing survival outcomes. So this is the number of patients that are alive after being enrolled onto the trial, and you can see actually that the survival outcomes, whether they get started on imatinib or another TKI, are all pretty good. Really, none of these trials, these comparative trials, have shown that there's been a survival advantage with second generation TKIs like dasatinib, nilotinib, or bosutinib, even despite having deeper responses in some patients. And so some of the pros and cons of the different treatments that we have available in the front line. So for imatinib, one of the major advantages is there is long-term safety data, and this is a drug that people have been using for over 20 years now, so we have a pretty good understanding of what the toxicity is, especially in the longer term. And it's significantly less expensive than imatinib. There was an estimate I read on average for generic imatinib, it's around $8,000 per year, compared to probably over $70,000 or $80,000 for a second generation TKI. The advantage of the second generation TKIs, like I mentioned, is they do have a higher rate of deeper responses compared to imatinib, and in trials there has been lower, slightly a modest decrease in the rates of progression to cell blastase. With imatinib, and there's a different side effect profile of these three different drugs as well, and these side effects are not thought to be related to the actual inhibition of the drug of the BCR-ABL protein, but called off-target effects where the drug can enzyme or another protein that a cell might rely on. And so we see the common kind of side effects that we see as big problems in terms of patients having to stop medication or change the medication would be problems with fluid retention or edema or swelling. Some patients have quite a bit of GI toxicity with symptom nausea or vomiting or stomach upset, as well as arthralgia and muscle pain and joint pain. And the side effect profile is a bit different. More common side effects that we see as big problems are pleural effusions. This probably happens in about 10% of patients, and this refers to the development of fluid around the lung, as well as some pulmonary hypertension, low platelets, and sometimes bleeding symptoms. And some downside of that drug is that sometimes we see it can be more of a challenge for some patients to take, where it's a twice-a-day dosing schedule, and you have to end up taking it on an empty stomach, which is a hassle for some patients. And probably a concern with nilotinib, some of the metabolic side effects where we see increased cholesterol and sometimes increased blood sugar. And in a small number of patients, there's been reports of what we call peripheral arterial disease, problems with the blood supply, particularly to the extremities. And this is a rare side effect that can be potentially a big problem, and patients that may have type of disease, some suggest avoiding this type of medication. And there's one that's being approved in the U.S. that I mentioned, and really this was on a trial showing an improved MMR compared to imatinib, and the major early toxicity is diarrhea, which tends to be manageable in most patients and to be limited, and less evidence of cardiac or vascular toxicity, and it is an oral once-a-day drug, and we have to see if this becomes available sort of as a frontline treatment here in Canada. And so what I want to talk about is this concept of so-called treatment for remission. Previously, it was thought that although TKIs are good drugs, they're something that needs to be continued indefinitely, or would ultimately relapse. And this was kind of challenged by a few kind of observations that some patients who were able to that stopped TKIs for various reasons actually didn't end up relapsing. And things about stopping a TKI or stopping a drug like imatinib or dasatinib is, why would you want to stop? Well, some patients have, as I mentioned, have adverse reactions to the drugs, hypertension or other serious reactions, and this definitely affect patients' quality of life. And stopping to have economic impacts for patients and governments. And then for certain patients, issues around fertility and pregnancy are also a reason they want to consider stopping their TKI. And studies that have been looking at this recently, showing a chart of the 10 different studies that have been reported recently. And some of these studies are looking at stopping patients after treatment with imatinib. Some are looking at nilotinib and dasatinib. And number here is showing the number of patients that were enrolled in each trial. Some of these patients have a very large number of patients. Like here, the EuroSki trial has over 7 patients, and some are relatively small, with only 40 patients. And really, the median follow-up time varies between the studies, with some trials being conducted for a very long period of time and following patients for a very long time, like the STIM1 study, where patients were followed for 77 months or over 6 years, and some trials only following patients for less than a year. But in general, it seems as though what we see from these trials is about what the number of patients that can achieve a treatment-free remission. So this means that patients are able to stop their medication and then don't have a molecular relapse or don't have to restart on the treatment. It's in the range of around 40 to 60% between the different trials. And so two of these trials for interest a little bit. One is the STIM1 trial, and this is a large trial of patients who stopped imatinib. And the patients that were eligible for this trial were only patients who had chronic phase disease. They had to be treated with imatinib for at least 3 years, and they have an undetectable remission for at least 2 years. And patients stopped their imatinib on this trial. They had molecular monitoring done every month for the first year, every 2 months for the second year, and every 3 months for the third year. And in this trial, they defined what they call the molecular relapse. And so this was either a loss of the major molecular response, or they didn't lose molecular response but had a tenfold increase in their molecular test over 2 tests. That was also a molecular relapse. And they had 100 patients in this trial. They had to follow up for longer than 6 years. And what they found was that of those 100 patients, 61 patients had a molecular relapse. Most patients relapsed within the first 6 months, the majority of patients. And predictive response was patients who seemed to be able to stop without relapsing for patients who had a low SOCAL score. This is a risk score that's based on clinical factors at the time of diagnosis, as well as patients who had longer treatment with imatinib before stopping also tended to be more successful. And patients that ended up stopping their imatinib, 57 of the 61 patients ended up restarting the TKI. Most of them restarted imatinib, 1 restarted dasatinib. And 4 didn't restart, 3 of them refused, and then 1 had a second malignancy, so they didn't restart. And of those 57 patients, 55 ended up achieving a second undetectable response. And there were no, even those patients that didn't achieve an undetectable response, there was no loss hematologic response or disease progression to a greater blast phase. And so, Canadian study looking at stopping, this is called the TRAD study, and this was conducted a number of different sites, and I think is now close to enrollment in Canada. And there was 3 phases of this study. One was similar to the STEM study, where imatinib was stopped. And there's a second part of the study where patients who had a molecular relapse were not on imatinib but dasatinib, and achieved another deep response. And there was also an attempt to try to stop the dasatinib at another time point. And so the final results of this trial are not because the follow-up isn't long enough, but there were some preliminary results that were at ASH, which is a big meeting in the US every year. So I thought I would just go over this. So this study included patients only in chronic phase. They were treated with 3 or more years of imatinib, and they have a response, MR 4.5, or a very deep response over 2 years, and didn't include patients who had accelerated or blast phase or prior allogeneic stem cell transplant. And so we enrolled 118 patients at the last report, and of those, 170 had kind of data to report on whether or not they had a relapse. Although this in this study was that 38% of patients lost their molecular response. So the 12-month free remission was around 66%. 4 lost their response. Patients lost their response, and of those 41 patients, 37 ended up starting on dasatinib. Those patients, 35 ended up achieving a major molecular response, and the median time was under the average time was under 2 months. And they only got on 7 patients who had a deep response after restarting imatinib and then subsequently went on to stop medication. And 2 of them ended up losing a response again at day 61 and 125, and 5 are still under monitoring at relatively early time points. So it'll be interesting to see what the results of this Canadian trial are. One question, or one thing that's not kind of captured necessarily in these trials is what a patient think about stopping. For some patients, that may be a very attractive idea, where they're quite keen to stop if they had a deep response, and for patients, there really be no interest in stopping. They may be tolerating the medication well, and they don't want to have the anxiety or hassle that may be associated with trying to do this. And this is just a screenshot of a Facebook group that's interested in this particular issue. And so really, who can consider stopping treatment? Well, it isn't necessarily standard of care at all centers, but people are starting to have a better idea about who this might be appropriate in. It's only appropriate in patients who have chronic phase CML, so patients who have accelerated or blast phase, or patients who have had prior resistance to a TKI treatment are not necessarily good candidates. Would be better after a sustained period of TKI treatment, so I said greater than 5 years here, although all of the studies had at least greater than 3 years. And patients really have to have a deep or sustained molecular response, and usually the time period is for at least 2 years, or this should be MR 4.5. And one of the most important things about thinking about stopping is that they really need to make sure that there's, at the center where patients are stopping, is that there has to be availability of testing to detect molecular relapse, and this has to be able to be done in a frequent manner, at least on a monthly basis. And there should really be a discussion between the patient and the treating clinician about what the risks and benefits of this are. And so think about how many patients, this is an exciting new area, how many patients this applies to. Probably only about 4% of patients who start a second-generation TKI are eligible to stop. Might be a generate type of estimate. And based on what we understand, probably only about 50% of these are able to actually stop without having a molecular relapse. So really we're only talking about 20% or probably less. We're probably talking about, say, 10% of patients with CML that this might actually apply to. For the interest of time, I'm going to skip over this slide. There are a number of kind of guidelines that people are starting to put together now around stop TKIs and the different kind of recommendations from the different groups. It's really an issue that's still kind of ongoing. So they wanted to talk about was second line treatment and beyond. So what are some of the considerations once in second line treatment? Well, there's a bunch of things that we have to consider, and really second line treatment is not sort of standard between different patients, and it's really individualized. And so one kind of important considerations is if a patient's second line treatment, was it because the TKI the first treatment didn't work, or maybe they didn't tolerate it? This is a different scenario. Disease progression, say to accelerated or blast phase, or the failure to meet one of the targets that I mentioned. Previous TKI, was it Imatinib, or was it a more potent second generation TKI like dasatinib or nilotinib? Is the mutational testing involved that the patient is resistant to a certain TKI, and are there other patient characteristics to consider? And so I was going to go over a couple of cases of patients. These are not real cases, so it's kind of things that I made up based on sort of a conglomerate of different cases that I've seen. So this is a case of a 64-year-old man diagnosed with chronic phase CML. He had a high SoCal score risk, and that is a bit less likely to respond to and he also had a number of other health problems like hypertension, diabetes, atrial fibrillation, or a heart rhythm problem, as well as prior stroke. And so he started on Imatinib Frontline, and he had a hematologic response after he started. He just barely met this less than 10% initial target. By 12 months, his B-serial transcript was still around 8%, and he really didn't look like he achieved a complete cytogenetic response. So he underwent a bone marrow exam. He confirmed this, and it looked like he was in morphologic remission, or no signs of CML in the cell on the bone marrow, but on the cytogenetics, he still have the Philadelphia chromosome in a number of cells. He did any additional cytogenetic changes and no resistance mutations on testing. So what's the best choice of the next TKI? Other potentially options. So when it's the treatment of patients in second line, then the results with the 4 different TKIs that are available. And just to summarize, that many patients still go on to achieve a response that we're looking for, like a complete cytogenetic response, but the rates are lower in the second line group, probably around 40% or so, and a fewer number of patients achieve this even deeper response. And so with survival, though, outcomes are still pretty good for patients that are going on to receive second line treatment. And we still see in these trials relatively few patients are actually presenting or progressing to accelerated or blast phase, which are more difficult to treat. in this example, in this trial, 10 patients progress into that when there's over 600 patients enrolled in the trial. And so this case ended up deciding to start on dasatinib. He elected not to start on nilotinib. A number of other risk factors for a vascular event. There was some concerns around starting on nilotinib, sunitinib, and bosutinib weren't available. So that was the decision of this patient. It's really individualized. This case is of a 35-year-old woman. In this case, she didn't have any other significant problems. And she also started on imatinib for 400 milligrams a day. She did have a hematologic response initially, and it did look like she had met our target of what we were looking for, a complete genetic response. But then after months, her transcript, BCR-ABL transcript started to increase again, and a losing response. So now what do we do? So we do a marrow exam again, and looks like she's in morphologic remission and has a very small number of Philadelphia chromosome by FISH, no additional cytogenetic mutations, but she had resistant, and she had the presence of a new mutation, a T315I mutation. So what's the next best choice? So this T315I mutation is sometimes seen in patients that are treated with TKIs, and this confers resistance, usually to treatment with imatinib, dasatinib, and bosutinib. And that's the one drug can overcome this mutation, but the concern around using ponatinib, especially in the earlier trials, is that there seems to be a high rate of vascular toxicity. So things like heart attack or stroke or other cardiac complications, ranging between sort of 25 all the way up to sort of 37% in early trials. But for a patient who has this mutation, it's still probably the only main choice. So she was starting on ponatinib for this mutation, and then her clinician ended up deciding to decrease the dose. She had a good response early on with the hopes of trying to reduce the risk of toxicity with the medication. And so I'm going to cover that. And I'm sorry, so I'm gonna stop it there. There's a few more slides that you're able to, I think, will be available on the website. But to field questions, just so I think it's probably good to have a little bit of time for questions if people have these. And so my main conclusions for the talk is that there's multiple options for frontline therapy, and outcomes are good for most patients with chronic CML. And second line or greater therapy is really individualized based on their therapy and disease status. Treatment remission is probably one of the biggest new areas in kind of the research field in CML, and I don't think it is necessarily going to change treatment right now for most patients with CML, but I think it potentially has potential to alter treatment, particularly if it becomes a new treatment goal where people are trying to achieve sort of a treatment-free remission. But there's still many unanswered questions around this, and it really needs to be done in an appropriate patient with adequate discussion around monitoring. And there's still, in CML, there's still a lot of work on novel agents and new approaches to treatment. So I'll start, and I'll be happy to take any questions that people have.
Great. Thanks, Dr. Sanford, for educating us today. Leukemia Lymphoma Society will continue to do its part to speed up the new discovery of better treatments. Now we'll take general questions. We have about 10 to 12 minutes, so please fill out the chat area on the side there, and we'll go from there. Here that's asking about how long does it take for there to be results in clinical trials?
Because we're clinical trials, I'm not sure exactly how long it was for each trial, but based on what has been published in guidelines for stopping, their general recommendation is that the PCR testing, the turnaround time for results should be less than 2 weeks. So patients are able to patients and physicians are able to get those tests in kind of real time able to kind of make decisions about whether or not they need to repeat a test or restart on treatment if there was a molecular relapse. Another point that I kind of made in the talk was that you really need to have a test, and not all PCR testing or all BCR-ABL testing is exactly the same across the site in Canada or throughout the world. And so you need to have a test that's quite sensitive, that's able to detect a low level of the transcript. And people would say that in general you need a test that's able to detect a M level of 4.5 or less than 0.03.
Up here is any studies that show results for reduction of dosages with Imatinib.
Not for Imatinib. People are less keen to dose reduce Imatinib. Some of the original trials actually looked at higher doses of Imatinib, like 600, 800 milligrams a day, as opposed to the 400 milligrams a day that's standard. And those trials did show pretty equivalent outcomes, but higher rates of toxicity with the higher doses or higher rates of side effects. There's as much comfort in reducing Imatinib sort of to like a 200 to 300 milligrams a day in general for CML, compared to, say, drugs like Dasatinib or Imatinib, where there is a bit more comfort because they are more potent around reducing the dose. So often if people are tolerating the Imatinib well, and there's other options for other TKIs, people might think about switching at that point.
That's asking, is it inevitable that medication will stop working at some point? Thinking that they're referring to, it sounds like Dasatinib.
No, I don't think it's inevitable at all. I mean, I don't know the specific details of the case. I'm not asking that or anything, but it's based on what we understand around the stopping data is that patients who have had a very deep response, they can even sometimes potentially stop the medication and not relapse. So there are a number of patients that are not on the sort of frontline starting dose of Imatinib, 100 milligrams a day, that end up getting dose reductions for various reasons, usually related to toxicity or side effects that still have disease control. So I don't think that's inevitable at all.
The question here is CML largely controlled while staying on medication? If it's largely controlled while staying on medication, are instances of chronic phase changing to accelerated stage?
This is a rare event, but it's definitely part of the issue or treatment of CML. Part of why I was talking earlier about some of the targets that we have, things like when we go and talk about a complete cytogenetic response or a major molecular response, these important targets on treatment where patients that meet these targets are very unlikely to progress to blast phase or accelerated phase if they stop the medication. Stay on the medication long term or not miss doses of the medication. So there are cases of that, but it's still a relatively rare event.
Regarding stopping TKIs at a certain number of years post-transplant, CML, or a number of years remission?
Many of the studies didn't always include patients who had an allogeneic stem cell transplant for patients. And usually the reason for that is that most patients that had, not all, but many patients in a more modern era who have had an allogeneic stem cell transplant, it would be the issues around like disease resistance or progression of the disease to the next phase. So usually those patients weren't included. And then the second part of the question was how long should they be in remission? So in patients who hadn't had a transplant, most trials led patients to treated with at least 3 years of treatment and then have a very deep remission for two of those years. So that was here for the trials, and the patients that were able to successfully stop, probably they had even longer treatment duration for probably over 5 years.
Okay, here, are there nutritional supports that are recommended while on treatment medications such as Imatinib?
Not really. There's no specific nutritional supports or supplements that are recommended. I think the big message would be that because CML is what we often start to think of it as more sort of a chronic disease, we know patients are living a relatively kind of normal life expectancy, is that we really kind of reinforce sort of healthy diet and healthy eating and exercise patterns that would be applied to most other patients in the population, with the goal of kind of reducing some of the long-term other disease problems like things like diabetes or heart disease. But there's a specific diet that I would recommend people avoid, and there's a lot of things around things like avoiding sugar and that type of thing in cancer and CML, and I don't recommend doing that because there's not a significant amount of evidence that those types of diets or kind of elimination diets are useful in the treatment of CML.
All right, we have that says, are there any common factors for the 20, this is referring to the clinical trial or one of the trials happening, is there any common factors for the 20% of patients which can stop taking medications for such a long period of time?
So, yeah, so the common factor is the long treatment. So patients that have been treated continuously with a TKI or Imatinib for a longer period of time tend to do better. And in the first STIM trial, as I remember just off the top of my head, I think they looked at patients on average in that trial have been treated for a median of 5.7 years. That's like the average time that patients treated. And patients that were treated beyond that 5.7 years had more like a better chance of being in having a molecular relapse. Now, not all of those patients, even in the patient group that were 5 or 7 years, not all of the patients relapsed, but it still gave you a better odds of doing that.
Yeah, well, I would like to thank Paladin and Novartis, as well as Collins Family Foundation for their educational support that makes this webcast possible. This afternoon, we sent you an evaluation form. Please fill it out. It will help us better meet your needs. And we also sent you the links to the website in case you'd like to find out more information about our services and research programs. You can check our website out regularly for dates of our upcoming webcasts at llscanada.org/webcast. Thanks for joining us today and enjoy the rest of your day. Thank you.